Now. Welcome to our afternoon breakout session. I hope you all enjoyed our keynote speaker, Zach Williams. It was a really wonderful presentation. And now we are in this breakout session of the Thriving Through Connections virtual conference. I'm very excited for this one. This presentation will introduce you to some of the latest research in neuroscience and neuropsychology, which explain the brain's responses in emotion processing, memory, mood, behavior, and more. Through a scientific lens, our presenter today strives to destigmatize mental health and mental illness and express the importance of mental health as a key health component. With his experience teaching and mentoring students, our presenter will address mental health in a university setting as well. My name is Blair Verasa, and I'm the project coordinator at ConnectOC and the National Council on Alcoholism and Drug Dependence, Orange County. It is my pleasure to introduce our speaker for this session, Dr. Michael Yassa. Dr. Yassa is a professor of neurobiology and behavior from the School of Biological Sciences. He's a professor of neurology and psychiatry and human behavior with the School of Medicine. He's a professor of psychological science. He also works at the School of Social Ecology. In addition to all of that, he is an associate dean of diversity, equity, and inclusion, works with the School of Biological Sciences. He's the director there. And he also works at the Center for Neurobiology of Learning and Memory. And he's also the director of UCI Brain at the University of California, Irvine. So it is my pleasure to welcome Dr. Michael Yassa.
Thank you, Blair, and thank you all for inviting me to be with you in this workshop, this breakout. I was told that I would have a little under an hour, and I wanted to make this very interactive, so I hope that you will all have an opportunity to ask questions, interrupt me throughout. The only thing that's difficult for me to see while I'm presenting, unfortunately, is the chat window, because this thing blows up on my screen and I can't see the chat window very well. So if there are questions aggregating in the chat, I would appreciate one of the moderators to just kind of chime in and say, hey, you've got questions in the chat that you might want to get to remind me. And I will ask you throughout also, I hope that you'll indulge me to unmute yourselves and give me some responses as we talk through some of the issues. So today I'd like to talk about destigmatizing mental illness through a scientific lens. And we'll start by talking about stigma sort of more broadly with respect to mental health. And then we'll talk about mechanisms and the physiology of mental disorders and how that scientific perspective on mental illness can really be used to try to destigmatize how we think about mental health and mental disorders. So I want to start just by a little brainstorming exercise. And this is a place where you all can unmute yourselves. I hope we can unmute everybody and just allow everybody to chime in. Just by show of hands or by chiming in, I want to hear if you've ever had an encounter with somebody in public that you might have suspected has a mental disorder or mental illness. Say on the subway, on the bus, on the train, out in public.
Yes.
Good number of us, right? Now, I want you to think about that experience a little bit, and I'm going to ask you a few more questions about it. And this is where, again, you can use the hands gesture. You can raise your hand up so I can see it, or you can just use the raise hand feature. But how many of you, in the context of that encounter, felt uncomfortable? Okay, and it's okay, we can be honest about this. It's all part of the discussion, right? And it's okay to feel uncomfortable. It's not an unnatural response. Do you feel that the person's behavior might have been unpredictable? Could that cause some discomfort? Okay. Did you feel that the person could have been dangerous? In some cases, right? Now think with me now, here, this is a place where you can contribute orally. What kinds of things was this person doing? Give me some examples of some behaviors, some activities that seemed bizarre, odd, unpredictable, or just made you uncomfortable. What kinds of things?
Undressing, yelling and screaming.
undressing, yelling and screaming. Other examples?
Jumping around like they were avoiding, like they were in a battle kind of thing, like they were actually engaged in some kind of combat. They were jumping back and forth.
Mm-hmm. So physical aggression, right?
Mm.
Okay.
Dr. Yassa, I'm seeing some things in the chat as well.
Would you mind, Blair, helping me out just by reading them out because I can't see them?
Yeah, I'm gonna read those to you right now.
Thank you.
Talking to someone invisible.
Yeah.
Drunk driving.
Mm-hmm.
Pacing and talking to himself, screaming. No eye contact.
Mm-hmm.
Throwing things. Talking to themselves and stealing their food.
Mm-hmm.
Screaming and being angry because they thought I was their sister. Talking to themselves and walking around unusually.
Okay. Now these are great examples because I think we paint a pretty wide swath here. Everything from personally can become uncomfortable because you might be subjected to aggression or violence, totally understandable. But in some cases, say someone talking to themselves or doing something that just seemed bizarre or odd might make you uncomfortable, but it's not directly impacting you in any significant way. And this is a really helpful discussion for us to have because we're trying to define what does it mean to have a mental disorder, right? So that's the next question for us. What does it mean to have a mental disorder? What does it mean from a societal and cultural set of norms? These individuals that you're describing violate some amount of those norms. So is that the definition, the appropriate definition of a mental disorder, that it violates our social and culturally acceptable norms? And let's take some examples. Anybody recognize who this is? The infamous Lady Gaga, of course. You know, the way she dresses, the way she behaves, short of the brilliant music, might be construed as not fitting with norms. It violates some norm, right? And that's part of what makes it appealing in this case. What about this individual? You guys may be a little too young for recognizing who this is. Marilyn Manson. By definition, right, deviates from the norm. Is that okay? Is that a problem? These are cases of deviation from social and cultural acceptable norms. And yet we celebrate and revere many of these examples in celebrity because of the entertainment value. Here's another one I want to share with you. You may not recognize who this individual is. Probably don't recognize him. This person is, for all intents and purposes, also a deviation from the norm. His name is Garry Kasparov. He's one of the top world chess players and has one of the highest recorded IQs in the world, 194. So in some ways, he's a deviation from statistical norms, right? He's a tail end of a spectrum. So the idea of deviation from some set of norms is quite common. But in the context of mental disorders, we tend to take it quite seriously. And it's easy to fall into the trap of thinking that a mental disorder is simply just a deviation, in which case it can be defined very differently by one culture, one society, or one individual. We want to do better, right? So how can we operationally define a mental disorder, not just as a social or societal construct, right? Not just as a cultural construct, but as a real physiological phenomenon. And that's the operational definition that we want to use for today. And those are the kinds of operational definitions that'll get us to also destigmatize mental illness, because it's not about deviation anymore from the norms. It's about impairment and dysfunction for the person themselves rather than the degree of discomfort in people around them, right? So let's go through this definition together. A mental disorder is a condition marked by sufficient disorganization of personality, mind, and emotions to impair the normal psychological function of the person. It is defined in terms of the extent to which it disrupts the person's day-to-day activities and life, right? It has to be an impairment. So just the appearance is not sufficient The degree to which it makes others around you uncomfortable is also not sufficient to really characterize as a mental health disorder or mental disorder. It's really the impairment that defines it this way. Now, how common is this? Well, mental illness affects 1 in every 4 individuals on this planet. And that's our best guess. Likely it's more. Certainly because of the pandemic, it's likely much more, right? But these are dramatic numbers when you think about just the sheer, the amount of the workforce that's impacted. In the US alone, 58 million American adults suffer from a diagnosable mental disorder, never mind the range of variability of subclinical and things that just have not been diagnosed. That's 26% of the workforce. That's a big old chunk. And in terms of the financial ramifications, the financial toll, the global economic burden by 2030 is estimated to go to $6 trillion just from mental illness. So this is a major, major problem. It's not subtle, it's not small, but unlike other physical disorders, you don't hear a lot of talk about it. Well, here's one conversation about it. This is from Tom Insel, the former director of the National Institute on Mental Health, who said that the economic costs of mental illness will be more than cancer, diabetes, and respiratory ailments put together. And he's absolutely right. He's absolutely right. And in fact, that's not even considering the fact that mental illness and other physiological conditions can collude and can work together and exacerbate both. So that having a physical condition, say like cancer or diabetes, and having a mental illness at the same time exacerbates both. The consequences for both are worse. So that toll is not even described in these kinds of statistics. We're not talking about comorbidities. These are just the straight up numbers. So this is clearly a big problem. What does it entail? What falls under that umbrella, and how can we make sense of it? And we're not going to talk about all mental illness. I'm going to talk about a couple of umbrellas that are highly relevant, especially to the college age population. The first one is anxiety disorders. Now, in anxiety disorders, there's many, many different ones, and they all share common circuitry. They all share common mechanisms in the brain, but they manifest differently. So social anxiety is one construct. That might actually look very much like not making a lot of eye contact, right, with people in public, or looking like you're really uncomfortable in public situations. Generalized anxiety disorder, which is sort of a perpetual level of an anxiety about everything that you do in day-to-day life. And it's quite a debilitating disorder in the severe form. We also have panic disorder, right, which has real physiological consequences, real physiological arousal associated with it. We have specific phobias, and those range. There's a ton of different phobias. In fact, there's a phobia for pretty much every class of item or thing that you experience. So some examples would include things like claustrophobia, fear of enclosed spaces, agoraphobia, fear of being around people, aviophobia, fear of flying, or my favorite one, and I had to write it down just so I don't forget it, is frigatriskidecaphobia. Anyone know what that is? Frigatriskidecaphobia is fear of Friday the 13th. There's actually a specific phobia related to Friday the 13th. Thank you, horror movie makers. And this is what they have created in our society. But, and it sounds like it's, you know, it's entertaining to think about, okay, well, there's phobias for all sorts of things. But when you think about the consequences for the individuals, it can be anywhere from mild to extremely debilitating, to the point where they won't leave the house for that fear, right? So it can be very, very significant. Obsessive compulsive disorder. This is a pretty high morbidity, especially in the US. And post-traumatic stress disorder, especially in the military population, victims of trauma, abuse, rape, burn, all sorts of traumatic events can have the capacity to generate a post-trauma perpetual stress disorder or syndrome that can last for a very long time and can be just as debilitating, if not more debilitating, than the original trauma. In fact, most of the time, it is much more significantly debilitating than the original trauma. So big umbrella under anxiety disorders. Then we have psychosis, or what we call schizophrenia. And schizophrenia is a really interesting psychiatric illness from the context of neuroscientists studying this, it's very interesting because it taps into a whole bunch of different circuits and the intersections among them, and it is thought of as a developmental disorder. So you can actually see elements of this very, very early during childhood, that then you can see it exacerbate and get worse and worse during adolescence and early adulthood, typically when full-on symptoms manifest. But schizophrenia is characterized by having what's called formal thought disorder. It's a disorder of thought form. So the way that your thoughts are constructed, that may seem trivial to you because you can put thoughts together and use language to speak about them naturally, but for someone with schizophrenia, that becomes very difficult. So the idea that thoughts are constructed fluently and cohesively and are not just tangential and circumstantial, that becomes very difficult for someone with thought disorder. There are delusions. So delusions are complete systems of belief that are irrational. For example, delusions of persecution, delusions of grandeur. Somebody might think that they have special abilities and powers, or that the CIA is after them, or something like that, because they have privileged information. So having this intricate system of beliefs that is non-factual is a delusion. And it goes hand in hand with hallucinations, which typically within the framework of the delusion are experiences of things that are not actually happening. So voices, people, seeing things, hearing things in the absence of actual sensory experience. And typically the hallucinations and the delusions work together to convince the person of this alternate reality that does not really exist. Disorganized speech, that happens not in every patient with schizophrenia, but in a subset of patients, typically the ones that have more severe thought disorder, they will have disorganized speech. Emotional expression is quite inappropriate. In some cases, not all, there's a catatonia syndrome, which is a complete immobility that can last from hours to days. And then finally, loss of touch with reality. And that leads to a loss of family and friends, loss of job, loss of resources. Schizophrenia typically leads to a downward spiral that can be really devastating for people's lives. So this is a devastating illness, one of the most profound illnesses that's known in psychiatry, and it impacts about 1% of the population. So it's not a huge morbidity, but still 1% of obviously, millions and billions of people is quite significant. Going on to clinical depression, which now we're getting into things that are far more common. So depression and anxiety, these are much more common. But clinical depression is characterized and really defined by certain criteria. And those criteria require a persistence in that state for some time. So depressed mood or loss of interest for more than 2 weeks, for example, would be a really important tenet here. It deviates from the person's baseline, and that's a really important criterion, and it's common across all psychiatric illnesses. So if somebody in general has a very low mood, that's not necessarily depression. There had to have been a baseline that does not look like that, so that this is a real deviation from that baseline that impairs the person's function to call it depression. Right? So change from baseline is really a critical entity here. If it's always been the same, that may or may not be depressive.
I have a question.
Yeah, go ahead.
So you said deviates from your baseline, but like, what if you've always been depressed, so you don't know what your baseline is?
Yeah, that's a really good point.
Assume you would be a happy person.
Yeah, no, and that's a really good point. And it's actually a very difficult question. It's an excellent question. Thank you for asking it. But it is a difficult question to answer. And there's a couple of different ways to think about it. If you can recall a time where you were not struggling with depression, for example, that can be used as information that a psychiatrist or a clinician can glean about what a baseline might look like. Sometimes information from informants, family members, friends, can be used to try to glean whether there's a real change from baseline. And sometimes the key is to say, well, if this is really debilitating, but presumably you had a point in time where you weren't feeling debilitated, let's talk about it from that respect. Rather than the feelings, talk about the level of impairment and how much it interfered with daily life. So you try to kind of create different variants of that baseline based on information you get from the patients, or the person who's complaining of this, as well as family members and people around them that might be able to inform on their state. But it remains a very difficult question. Understanding someone's baseline is not easy. In some cases, it requires trying to intervene and seeing if you can achieve a different baseline, right? So let's say that there is treatment and all of a sudden you do feel better and everything improves. Well, that tells you that actually that might have been the baseline, right? But you might have been stuck in the depressed state for long enough that you forget what that looks like. So it's a very difficult question for clinicians to address, but it's one that you have to kind of do the detective work a little bit and ensure that there is a baseline there somewhere.
Okay, thank you.
Of course. I can't see the chat, but if there are other questions there, do folks have other questions they want to ask?
Yes, one was just posed in the chat. Is depression noticeable, like from another person's perspective?
It can be, but not always. Sometimes it's very difficult to discern, especially if you're concerned about a friend and trying to understand whether that friend might be struggling with depression. Sometimes we will go to lengths to hide it. And, you won't hear, I don't feel like going out because I'm depressed. You'll hear, I don't feel like going out because my back hurts, right? Or I've got too much to do. So you may see a lot of masking of those symptoms, which makes it very difficult to kind of get through that and really reach out and try to help someone. So not always. It's sometimes it's completely invisible. Sometimes it's a complete surprise to family members and to friends because of stigma, because of shame, because of all sorts of emotions that run around it. Sometimes it's cultural beliefs that make it very difficult to be upfront about what you're feeling. So just because you don't see the appearance on the surface doesn't mean it's not there, unfortunately.
Dr. Yassa, we did have one other question that came in just now, and you might address this in your future slides, but is situational depression considered the same as clinical depression?
Yeah, another great question. And actually, I was going to talk about that a little bit just in the next couple of points here, but let's address it now. No. So, for example, if there's a loss of a job or a loss of a loved one or grief or a nasty breakup or something that really instigates a lot of negative emotion that is highly situational and time delimited, that's not depression. That is a normal, natural reaction that we can have to these events. That said, situational depression can sometimes trigger full-blown clinical depression. So the idea is that it depends on how time delimited it is. If there is recovery, then you can conclude that safely that it was situational, it was something related to circumstance, and now that the circumstance is over, it's okay. But if it perpetuates itself after that circumstance is over, likely it has triggered a more clinical and subversive form of clinical depression. So that's when really the need for help arises, right? If you've given it enough time for grief to complete itself, the process, and now you're still struggling, that tells me that it looks a lot more like something more like clinical depression. And it may have always been there to some extent. It may have been underlying and just kind of masked or kept under control. And it was the situational event that was kind of unmasking it, or it might have been the straw that broke the camel's back. It might have been the thing that really kind of pulled it to the surface and made it much more clear and apparent. Okay. So impaired function is, again, very important. It has to be something that really impacts the person's day-to-day function, whether it's their job, their schooling, family members' obligations, responsibilities, taking care of kids. All of those things tend to suffer when somebody is struggling with clinical depression. And then there's a whole host of specific symptoms, and you have to satisfy a subset of these. But they include things like being irritable, not taking pleasure in activities that used to give you pleasure. So here's a deviation from the norm, what we call anhedonia. The idea is these activities used to be pleasurable in the past. They might have been a hobby or good food or exercise, and now you just don't take as much pleasure in those things again. Change in weight, change in sleep habits, fatigue, loss of energy. Those are all potential symptoms. and then and trouble concentrating and so on. And then there's a couple of things that are always kind of red flags and much more alarming, especially if you see them, if you feel them, and or if you feel that a colleague or a friend or a sibling or a family member is experiencing this. That's when you're seeing kind of the more severe case of clinical depression manifest. And that has to do with guilt and feelings of worthlessness, even passive suicidal ideation, right? Ideas about suicide, ideas about not existing anymore, ideas about wouldn't it be great if I just wasn't here, right? Those kinds of things usually are initial stages of much more dramatic suicidal ideation. And I don't need to tell you, suicide is a major, major problem. And, you know, the NIH right now is investing a lot of resources into trying to develop new therapeutics and new mechanistic understandings of the kind of severe depression that could lead down the path to suicide. But by all intents and purposes, our job should be never to let it get this far, right? Not just in ourselves and seeking help, but in everybody around us and being vigilant and looking for those signs, even though they may be hidden. And if they're hidden because somebody's closed off, you got to ask questions, you got to probe. And even if you end up thinking, well, I might lose their friendship because right now everything is comfy, cozy, and we're just, you know, we hang out and we laugh and we have a good time. I don't want to get too dramatic. I don't want to get too serious. Rest assured that you know, you're not going to lose somebody's friendship in the long term if you get serious and you really want to help them. They may situationally at that point in time not really understand it and appreciate it, but in the long run, I think that once they understand the impact of what you're doing is, they will appreciate that you were there for them. Couple things that you know, I don't want to get too alarmist here, but just so you know, these are underreported statistics, but I want to share them with you anyway. Always underreported because people don't talk about it as much as they should. But the numbers are staggering. So 86% of all college students report being overwhelmed or having felt overwhelmed. 81% having felt exhausted. You should automatically see overwhelmed and exhausted as some of those symptoms, right? And the masked reporting of potential depression. 30% of college students have felt too depressed to function. These are their actual reports. 6.6% of college students have seriously considered suicide. And again, these, like I said, are underreported numbers. Likely the numbers are closer to about 150% of what you're seeing here. So it's a difficult problem to address. Now, you heard today from Zach, and it's interesting because at this time, and I remember this very, very vividly, when Robin Williams passed away, he took his own life, as you all know, and you've heard from his son today. The discussion about depression in the media just exploded because before then, I don't think there was a lot of awareness about how this could impact people that were totally seemingly happy and normal, that you would not think in a million years would be having suicidal thoughts. But it also made me realize, and I think made the community realize, that not only were we refusing to talk about mental illness, but as a problem in our society, we were making it illegitimate to talk about it. We were criminalizing it. We were making it a liability. We were making it very, very difficult for people to come out and say, I am struggling with depression. So I think that this incident was a wake-up call for a lot of people to really tell us that we have to have these conversations. And no matter what the outside appearance looks like, what could be going on the inside could be far more severe. But it is difficult, and it was difficult in 2014, and it continues to be difficult today, although maybe we're a little bit more open to talking about it. But it's difficult because of the stigma. It's difficult because of things like this, right? The words and the dialogue that you hear from those who don't understand what you're going through, like quit being such a downer, right? Or you're making a big deal out of nothing, or just snap out of it. Often we'll hear parents saying things like that to their children who are struggling with depression because they themselves don't understand it often. And maybe this is a little bit more, you know, culturally delimited to specific cultures, especially parents who have immigrated to the US, who have worked very, very hard. And you'll hear things like, we didn't have depression in my day. we worked hard, and we appreciated everything that we had. And why are you being like this? And there's a lot of blame, right? And it comes from an uninformed position. It doesn't come from malice. It comes from a lack of knowledge. Things like you're just looking for attention, right? Or maybe not saying it directly to you, but saying it about you. They're just looking for attention. They're just trying to get attention, right? Or you'll get over it. Just try harder. Or don't worry about it. Just come out to the party and you'll feel better. And we have to realize that that does not solve anything, right? We can't tell cancer, just get over it. Same thing. We can't just tell somebody with depression, just get over it, right? And you'll be fine. Just stick it out and you'll be fine, right? You have to get help. We have to get help. So what are those myths that make it very difficult? What are those impressions that friends and parents and some of us, many of us, have that make it very difficult for people to get help? Well, first, the idea that mental illness has no physiological basis is a myth. It is absolutely not true. There is no difference, and I say this as a neuroscientist who studies this very topic. There is no difference between a mental disorder and a physiological disorder. There's nothing that happens outside of your brain, right? So what happens in your brain is 100% physiological. There's no such thing as purely behavioral kinds of things or choosing to act in a certain way. That's not how that works, right? Every mental illness has a real, detectable, measurable physiological basis. For young adults, some think they're simply acting out and that they'll grow out of it, right? It's rebellion during adolescence, thinking about suicide during adolescence. It's just normal. They'll grow out of it and they'll be fine. Maybe that's true some of the time, but a lot of the time it's not. A lot of the time it is a symptom, it is a sign, it is a set of phenomena that are happening for a reason, and they have a physiological basis. Also, this belief that mental disorders have something to do with being weak-willed or less intelligent, that if you say I am depressed or I struggle with anxiety or PTSD, that somehow that makes you appear to others like a weaker person, or to not have the willpower to be able to overcome this. It comes from this notion that somehow it's within your control. And at the end of the day, it's because of fear of the unknown, right? People fear and express bias towards what they don't understand. So where we can do better is by enhancing that understanding, is by being able to have a much better idea of how mental illness impacts the brain. So let's talk about that. What are some of the physiological bases? Of course, I can't cover everything. We would take us a whole semester where I can teach you about the neuropsychiatric or neurophysiological basis of psychiatric disorders, but I want to give you some highlights. We know, for example, that depression is associated with increased levels of stress chemicals in the brain, glucocorticoids. And we know that that has a real physiological impact on the brain. It reduces dendritic spines. These are little projections that protrude off of brain cells that allow for plasticity to happen, that allow for connections with other cells to happen, that allow for learning and memory to happen, that allow for decision-making to happen. And you're reducing those. You're reducing your capacity for learning, your capacity for cognition and thinking using these glucocorticoids. So that's a real impact of depression. If you look deep within spinal or within dendritic spines, within dendrites, you'll see that these things are highly dynamic. This is a brain cell, and what you're seeing here are dendrites. And the little protrusions, it's going to zoom in a little bit, these little protrusions, each one of those is a spine. Each one of those is labile and able to make a connection with another cell. By eliminating those spines, by removing them from the dendrite, you remove the capacity of that cell to make connections and learn. This is such a highly dynamic process, and it's regulated throughout the entire brain. The good news is when the stressors are removed, these things can regenerate, right? So cells that maybe didn't make as many connections because of stress, because of depression, can go back and rebuild those connections once that stressor is removed or once the depression is treated. A couple of other examples. If you look at the dendritic trees that these dendritic spines are nestled onto, You'll notice also dendritic arbors shrink, dendritic trees shrink. So the entire structure of the cell changes in someone who's depressed versus somebody who's normal. If you look within the hippocampus, which is a region in the brain that's highly involved in cognition, learning, and memory, you'll notice a few really key effects. One is that because the hippocampus is highly responsive to glucocorticoids, it has a high concentration of those receptors, it is one of the first regions in the brain to respond to stress and depression. What you find is cells are less excitable, so they find it more difficult to learn, and we all know this to be true. When you're experiencing depression, you find it incredibly difficult to learn new things, to study, to do well on exams. Well, because that machinery in the brain that's involved in learning and memory is disrupted. Its capacity to learn new things is disrupted. We also find that the ability to generate new cells, or what's called neurogenesis, in the hippocampus is also disrupted. And finally, we find, again, this dendritic retraction of the arborization of the dendritic trees that allow for all those beautiful connections to be made. All of that also gets retracted. But the good news is, again, when you remove the stressors or you treat the depression, these are all reversible effects. Notice I didn't say anything about cell death, right? Or a neurodegenerative change, or just brain death. It's not like that. It's not degenerative. It is flexible. It is a relapsing, remitting process. And whenever there's relapse, you get these effects. Whenever there's remission, you get reversal of these effects. And that's why you start to see symptoms improve and people feel better, right? Because these effects are getting reversed. If you look at brain volume, so this is a way to be able to measure this in humans, so much more kind of large scale, and compare the brains of those with depression to those who don't have depression. You find that there is reduced gray matter volume, and in this case, it's not because of a reduction in number of cells. It is much more likely the number of dendrites, the number of dendritic spines, the number of synapses and connections in many brain areas, including the hippocampus, but also the amygdala, the emotional center in the brain, the entorhinal cortex, the basal ganglia, the thalamus. All of these regions are involved in so many different cognitive processes in the brain. They're sort of ubiquitous. And what that means is that when somebody is depressed, all of the elements of day-to-day function, whether it's your psychomotor speed, your ability to drive a car, your ability to study, your ability to think, your ability to talk on the phone, to read a book, to do all of these things, all of that is disrupted. The thinking machinery in the brain gets disrupted. And this gets worse when left untreated. So at the bottom left here, you see total hippocampal volume as a function of the number of days of untreated depression. And you can see that it's a linear slope, right? So how do we disrupt this? Start the treatment early. And the treatment doesn't have to be pharmacological. We're going to talk about those kinds of treatments, but there's a wide variety of different types of treatments, and everybody's different. And everybody's custom formula, depending on their brain and depending on their symptoms and how long they've had it and their family history, different things might work for different people. So it's a little bit of exploration to try to figure out how to best get help or to help someone. Also, if you look at metabolism in different parts of the brain, you'll notice two things. This is from classic PET scans. This is positron emission tomography. These are scans that look at glucose metabolism throughout the brain. And what we find is that in those with depression, there's decreased metabolism in the frontal lobe. Now, the frontal lobe is the most highly evolved part of the brain for humans. That's the part that allows you to have complex decision-making and do all of those wonderful things that we tend to think of as, you know, higher order cognition. Well, if there's lower metabolism there, you can imagine that the day-to-day functioning is going to be disrupted. And we hear that a lot from those with depression. Patients, when they're experiencing depression, they will say, I feel like I can't function, like I can't think. It is that disruptive, right? It's not just about emotion and feelings, it's about thinking as well. Broadly speaking, if you look at what's happening in the frontal lobes, you notice two things, actually, two regions in the prefrontal cortex that are dysfunctional, but in different ways. The first one, let me move this out. The first one is the ventromedial prefrontal cortex, which is this little hunk at the bottom in red, right? That's the part of the brain that's associated with self-reflection and generating emotional kinds of reactions. And typically negative emotions are generated in this area because of its connectivity to places like the amygdala. that's a spot in the brain that you find is quite hyperactive in depression. So it's on fire, it's really lit up. When you do MRI studies, you see it, hyperactivation. But the dorsolateral prefrontal cortex, which sits right on top of it, and what you see here in blue, that part of the brain, which is associated with the suppression of negative memories and negative emotions, and the reappraisal or reinterpretation of thoughts into a positive light, that part, sort of the rational thinking part of the human brain here, that part seems to be suppressed or hypoactive in depression. So there's an imbalance phenomenon, right? A functional imbalance in these regions that leads to a negativity bias and a lot of rumination over negative thoughts and memories. And what we tend to see is that with effective treatments, when you see symptom relief, that imbalance gets restored. So it's a shift where the DLPFC, the dorsolateral prefrontal cortex, starts to take the reins again and starts to get involved in this reappraisal to allow for the management of the kinds of things that are generated by the ventromedial prefrontal cortex. So here's a circuit type mechanism for depression that we see.
I have a question.
Yeah.
So the slide before the last one with like the colored brain, can you explain like which colors mean a lot of activity and which ones mean low activity?
Yes, thank you. So here, the red is highest levels of activity. And even though there's a lot of red back here and a lot of red back here, really the most significant and most salient is the loss of red that you see here when you go to the depressed patients. That frontal lobe metabolism or glucose metabolism is disrupted in those with depression, okay? So the loss of red here and also here, these are the basal ganglia. The loss of red here seems to have quite a bit of impact. Okay?
Okay, thank you.
Of course. All right, let me get past this one and go on to risk factors and potential causes. This is where it gets a little complicated. But risk factors, a family history of mood disorder could increase the risk. Not deterministic, but just increases risk. A history of physical, emotional, or sexual abuse, early trauma, that could exacerbate it, can make it more plausible. Major life events like death of a loved one, loss of a job. Remember, we talked about situational depression. That's not what this is. This is situational events really exacerbating or triggering or increasing risk for a more subversive form of clinical depression. Other mental illness. So depression tends to be highly comorbid with an anxiety, and you also see it quite a bit in the context of schizophrenia. So these things don't operate in silos. They go hand in hand. They work together. So depression and anxiety are very highly comorbid, up to 70% comorbid with each other. Other serious illness, cancer, for example, autoimmune disease, typically more lifelong or chronic conditions can be associated with mental illness. A history of or current substance abuse, and that's a feed-forward cycle. So a lot of times the substance abuse can increase the risk for mental illness, but also as a way to try to self-remedy, substance abuse can be used in an unhealthy way to try to deal with the symptoms, but it actually ends up making it worse. Okay. So I just want to capture a little bit, this is not going to be a lesson in biology or synaptic transmission, but the notion that there is a real chemical exchange of neurotransmitters that happens at the interface of one brain cell with another is really important, because all of the therapies that we have right now act on these receptors. And when I say receptor, I mean one of these little guys right here. If you can see my pointer, right? One of these little things that is nestled in this postsynaptic neuron membrane, that's a receptor. And every single one of those channels or receptors is able to bind with or accept incoming neurotransmitter from another cell. So that's the layer of control that we have in terms of pharmacological therapies. By being able to either inhibit those receptors or potentiate their activity, enhance their activity, we can control the amount of neurochemical that is there in the system. And that can change symptoms because it changes the way these cells function. So what are some examples of this? What are pharmacological treatments that are out there? And you already know about a lot of these. So I'm going to just kind of go through this in not a lot of detail. But monoamine oxidase inhibitors, MAOIs, those have been around for quite some time. They prevent the breakdown of a certain class of neurotransmitters called monoamines. NE is norepinephrine, 5-HT is serotonin, DA is dopamine. And I'm sure you've heard about things like serotonin and dopamine before. Tricyclics block the reuptake across all of the monoamines. And then there's ones that are maybe a little bit more familiar to you, SSRIs, selective serotonin reuptake inhibitors. This is sort of the class standard right now. And those are intended to block the reuptake of serotonin. So things like Prozac, Paxil, Zoloft, Lexapro, all of those are different variants on SSRIs. And SSRIs actually have a pretty good track record, somewhere between 60 to 80% effective. And believe it or not, for mental illness, that's really, really good, right? For heart disease, it's not. You want like 99% effective, right? But for mental illness, because we still poorly understand how the brain works, getting 60 to 80% efficacy is pretty good. There's also a couple of other classes that are a little bit more recently developed, like SNRIs that block both serotonin and norepinephrine. Cymbalta and Effexor are some of the newer ones there. And then NDRIs, norepinephrine dopamine reuptake inhibitors. Those are a little bit more geared towards older adults, depression. Things like Wellbutrin, for example, are blocking the reuptake of both of those together. I want to tell you about one recent advance that you may have heard about. And this is really interesting. And keep in mind, I am not telling you to go out and get ketamine. Please, for the love of God, do not go out and get ketamine, because it can kill you, right? But with that in mind, understand that ketamine actually has been one of the most exciting things to happen in clinical psychiatry for a long time. So why do I say ketamine? Well, this appears to be a new therapeutic avenue. It was originally used as a battlefield anesthetic in the 1960s, Vietnam War. This is what they used, really, battlefield medicine. It's been for a long time and still continues to be abused as a club drug, as a date rape drug. It has dissociative effects, so it can cause hallucinations and dissociations from reality. But interestingly, it can rapidly reverse symptoms of severe depression and suicidality. In clinically monitored settings, this can be administered. It can actually reverse those effects within hours, not days, not months, hours. It can be administered in an IV infusion, typically within a medical center, while closely monitoring, because the amount that comes into the system has to be very well regulated. Again, high amounts, high doses, or anything that's not regulated can be fatal. This is a drug that actually kills people if given in the wrong quantities. The mechanisms are still under investigation, but it's possible. One of the prevailing hypotheses right now that inhibits, that the mechanism is inhibition of NMDA receptors on inhibitory interneurons or GABAergic interneurons. So in some ways, it's inhibiting the inhibition. And as a result, you start to see a lot more potentiation and excitation in the frontal cortex, and that might remediate some of the symptoms that we're seeing. Importantly, the FDA last year in March approved S-ketamine, which is the S enantiomer of ketamine. It's a less potent form of ketamine by taking a chemical composition that is a little bit less likely to be absorbed quickly. And it's a nasal spray form that's been approved by the FDA. And I think it can be prescribed right now by any clinician in conjunction with another oral antidepressant, typically an SSRI. So those two work hand in hand. It does not work anywhere near as quickly as a ketamine IV seems to be. So it's not something that is going to be used to remediate symptoms within an hour, but certainly it is continuing to be used in that fashion. And there's a lot of development efforts ongoing right now to try to figure out what about ketamine seems to be the effective mechanism. Can we develop safer and better drugs that tackle that same mechanism but maybe don't have those kinds of effects? Non-pharmacological treatments also have a strong history of working really well. Physical exercise. We know that physical exercise enhances hippocampal neurogenesis, increases the production of brain-derived neurotrophic factor. This is like brain fertilizer, stuff that's really, really good for your brain, nourishes cells and keeps them happy and healthy. Increases endorphins. I'm sure anybody who's exercised long enough, you get that endorphin rush. Those are all very positive things, and typically that can counteract depressive symptoms. And those who are regular exercisers, especially with COVID, gyms shut down and so on, and they find it very difficult to exercise. We got a huge uptick in depressive symptoms because regular exercisers are not able to get their exercise fix anymore. So it's something to really think about, because exercise can be a very, very potent modulator of these mechanisms. Things like mindfulness and mindfulness-based cognitive therapy, or MBCT, which is a combination of mindfulness based stress reduction, or MBSR, and cognitive behavioral therapy. So it's mindfulness meditation and the cognitive reappraisal. And that seems to work as well as medication in some clinical trials to prevent relapse, and also seems to counteract not just the depressive symptoms, but an anxiety symptoms. So early life adversity, for example, those who experience depression early in adolescence or in early adulthood seem to also be able to benefit more from MBCT, just using some of the extant data that we have right now on these. But again, there's more and more research that's being done on these approaches. Finally, a non-pharmacological approach that I want to tell you about is something that you may only know about from watching movies, and it might seem like it's very, very invasive, and in fact, it's actually quite safe and non-invasive. Electroconvulsive therapy. Sometimes people call electroshock therapy. I don't like to call it that at all because there's nothing shocking about it. It's actually quite safe. And it's used for drug-resistant depression. When people are actively suicidal and not responding to drugs, this can actually be very, very helpful. It does have some disadvantages in that relapse is still pretty high, and you do get memory deficits. So one approach to be able to deal with that is using right unilateral ECT, which, because it's not bilateral, it doesn't cause some of these issues with memory deficits, but it's you have to do more applications to be able to get the right effects. One thing that I'm excited about is the use of transcranial magnetic stimulation, or TMS, in particular repetitive transcranial magnetic stimulation, as potentially a new promising treatment for depression. It's been used with some success in bipolar disorder, and it's being applied now to variants of depression. And we just need to wait on more data to be able to conclude whether this is going to be a clinically viable path forward. Okay, so finally, how do we fight the stigma? Now that I've given you hopefully some of the weapons to do that, you got to know the facts. And education is key. Knowing the physiological basis, knowing how the treatments work, knowing that these are all brain circuits that are dysfunctional and can go back to being functional again is important. Educating others and disseminating that knowledge and making sure everybody has correct information about the physiological basis of mental illness is really critical. Being aware of your own attitudes and behaviors towards others. Being inclusive with your dialogue. Not using things like, oh, so-and-so is crazy. Right? Not using that terminology that can really marginalize and be exclusive of someone, but really being understanding of what they may be going through. Eliminating prejudice and judgmental thinking. Same way that you try to do it when it comes to other issues, like racial bias, which is a big topic that we talk about now, and using the right kind of language and being much more sensitive and inclusive, while you do the same thing with mental illness as well. Supporting people and treating them all with dignity and respect is really, really important, and including everyone in your dialogue, in your outreach and communication without discrimination. I just want to leave you with this parting thought from Bill Clinton. Mental illness is nothing to be ashamed of, but stigma and bias shame us all. Really, it's the stigma that's the biggest problem, because mental illness is highly treatable. So if you're suffering, if you're struggling, please speak up. And if you just want to help, spread the word. Thank you all.
Thank you so much, Dr. Yassa, for your time today. Blown away by all of the research. My scientific brain over here is so excited. I love seeing research like that and getting into more of that kind of clinical setting and approach. So thank you so much for sharing all of that with us today.
Very welcome.
I have a few questions that I wanted to get to and make sure we address before our session wraps up. So I'm going to start with the first question we received, which is from Brittany, and she writes, is it easy to differentiate between seasonal depression and clinical depression?
It is, but you have to give it time to understand its seasonal nature. So typically seasonal depression does, it's not just about seasons, it's really about, the weather and sunlight and being exposed to those seasonal tendencies that change your circadian rhythm and shrink your day. The typical solution, though, for seasonal depression or seasonal affective disorder is pretty simple. Light therapy is very effective. So one quick way, instead of just waiting to see if it resolves, one quick way to do it is to try light therapy with a clinician, just based on the advice that you get from a clinician. Trying something like light therapy and seeing that it works typically tells you, yeah, it's at least partially seasonal affective disorder. But light therapy doesn't work very well for clinical depression that is not induced by a circadian rhythm change. So that might be a good litmus test to figure out if it really is seasonal affective disorder. But there's also evaluations that clinicians can do and questions they can ask to try to do the detective work to figure out if it's seasonal or not.
Thank you. Our next question was from Nancy, and she writes, how do you teach your loved ones to live with someone dealing with a mental illness, and how do you help them to help you?
So this is a very, very difficult question, because in some ways, teaching someone to live with someone and to support someone with mental illness also involves making sure that this person who's doing that supporting is getting their own support. It can be so demoralizing, so painful, and so challenging, all the way downright to aggression. And not having the tools to deal with it yourself when you're caring for someone who's struggling with mental illness can make the problem even worse, because then it's not just them struggling, it's you struggling as well. So this is a place where I would say, exercise good judgment. You have to, if you're committed to helping this person, absolutely, but you need to make sure you don't lose yourself in the process, and that you're able to vent and have counseling and therapy and someone to talk to. There are groups that are really good for this, and support groups that are really good for this, for those who are supporting patients with mental illness. In the context of depression, it's difficult. In the context of schizophrenia, it's damn near impossible. It is so difficult and challenging to deal with a patient with schizophrenia. So that's really where people need help. But that's, talking and counseling and support groups and therapy are wonderful, wonderful things. And I hope that there's, sufficient knowledge now to not have stigma around those things.
Yes, thank you. Another question that we had from Leon, I'm sorry if I'm saying your name incorrectly. Do you think ECT is always accurate? Could there be room for errors that would heavily affect one's cognitive brain?
ECT is difficult because we still don't understand the mechanism, right? We're talking about essentially giving a jolt to the brain by inducing a limited seizure. And we know that seizures activate a lot of the brain circuits, produce a lot of neurotransmitter, and they cause some neuronal sprouting and dendritic sprouting almost immediately. But we don't know exactly, we can't target it to know exactly where that's happening or to know exactly which circuits are going to benefit most from this. What you do know is that the brain is sort of in a quite suppressed, inhibited state, and that ECT is able to give it that jolt to bring it back up to baseline, but no one has a clue how that actually happens. So the notion of it being accurate, no, I think it's the farthest thing from it. I think it's a hammer approach, not a scalpel. But when you have very severe depression and suicidal ideation and patients that are truly at risk, sometimes this is the last resort, and it's the only way to get them out of it. And a lot of times it's the beginning, it's the initiation. So you start with, a course of ECT over several days, weeks, and then you shift over to medication. And the idea is that you're able to bring them up to a sort of a functional baseline where then they can start to benefit more from other treatment options. Okay.
Thank you. We have a couple of questions here, so we'll try to get to them all before our session wraps up. We have, I believe, 3 more. What are ways we can alter our default mode response if it is mainly depressive?
Yeah, I would say check the statements first and make sure that that's truly the case, right? So the default mode response should not, under normal circumstances, be mainly depressive, right? And if you're thinking about the default as just the current status quo, and that is depression, then the best way to do it is to seek therapy right away. But if the question is much more asking about whether there's sort of a low level baseline unhappiness, or what's called dysthymia, which is kind of a milder but much more perpetual and long-term chronic version of depression, then that's also treatable, and it does have a lot of elements that are in common with depression, but you don't ever want to say that's the norm if it's truly depressive, right? So remember, we define depression, dysthymia, all of those disorders simply by how much they deviate from your own norm, not societal and cultural norms, your own baseline, your own norm, what is normative for your brain. So the first question has to be, what is normative for your brain? And that's where some of that detective work to try to identify, were you at some point in the past at a happy place, you enjoyed hobbies, you enjoyed activities. You got to go back to that time or get help from family and friends to go back to that time to identify how much of a differential this is, and then identify a goal state that you want to get to with therapy, right?
Yes, thank you. We might just have time for one more question, so I apologize if we don't get to your question today. Our last question is, how do I go about telling my parents I need therapy?
I think first you have the courage and conviction. You want to do this, and that's the start, right? I mean, so I applaud you for wanting to do this, because oftentimes people don't even want to take that step to say, how do I get there? I would take a very informed approach and say, I want to have a discussion about mental illness, and I want to tell you what I'm going through from a physiological standpoint. Here's what I know. Here's what I've learned. Here's the literature. Here's something that you can read about it so you can understand what I'm going through. And I'd like to get therapy. The response from parents, you can't guarantee. Sometimes that will still be very challenging. The best advice that I can give you, and really this may not generalize to everybody, but if you reach out to parents and you're vulnerable and say, this is what I need, and here's how you can understand me, and you don't feel supported, look for that support elsewhere. Because it's like pounding your head against the wall, trying to convince somebody that you need help. But you got to find a support system that offers you that. So if parents can't help you there, do it on your own. Go seek therapy on your own and find another support system, friends, relatives, siblings, other people that might be able to be there for you. I sincerely hope parents will be there for you. And I think that given the right information, given, we're assuming inherent goodness here, every parent wants to make sure that their child is not struggling. But sometimes parents can get lost in the, I know better. These are the problems of today, because, society is so weak and fragile that everybody complains about depression, but you'll just get over it if you work hard enough, right? Mm-hmm. So I would definitely seek support elsewhere if that's the case.
Thank you so much, Dr. Yassa, for answering all of these questions. I apologize again if we weren't able to get to your question today. But again, thank you for sharing all of this research with us. Thank you for sharing this knowledge. I think it was so beneficial for so many. I'm seeing such great reviews in the chat conversation from this presentation. So thank you.
As we're all saying very, very nice things. I'm going to put my email address in the chat. Feel free, if you have questions you want to follow up on, shoot me an email and I'll be happy to help or email you back with answers. Thank you all so much, and keep up the good work. This is truly terrific. So
thank you. Sorry. Our next breakout sessions will be happening at 3:30, so make sure to hop back on for the next sessions. Again, you can access those sessions if you click to the auditorium. There's the full breakdown of the list of speakers and the topics, so go ahead and click over there to access the next session you'd like to join. And remember to keep interacting. Head to the leaderboard tab in the menu bar if you'd like to, interact with our scavenger hunt and any other features and earn some points to win these prizes today. So again, thank you so much, Dr. Yassa, and thank you all for participating. We will see you shortly in our next session.